This video is about venous thromboembolism. Venous thromboembolism is characterized by the formation of blood clot in the venous system, that is deep vein thrombosis, and the subsequent dislodgement or embolization of the clot to the lungs by the way of the pulmonary artery, resulting in the pulmonary embolism. The pulmonary embolism and deep vein thrombosis are clinical representations of the same pathogenetic mechanism and share the same basic therapeutic approaches. It is believed that more than 500,000 patients are diagnosed with a venous thromboembolism in the United States yearly, and around 200,000 patients die every year as a result of the PE. The mortality of untreated venous thromboembolism is very high, around 30%. It is believed that it is a major preventable cause of death in hospitalized patients. Therefore, we can say that DVT prophylaxis is an important and often overlooked intervention. Pathophysiology. 75% of the thrombi are generated in the deep venous system of the lower limb and the pelvis, probably initiated by platelet aggregation around the venous valve sinuses. The activation of the clotting cascade leads to thrombus formation with Virchows triad, which is the venous stasis, injury to the vessel wall, and the increased blood coagulability, predisposing to the thrombus formation. The venous stasis is increased by immobility and dehydration and leads to local accumulation of the platelet and the clotting factors. In addition, coagulation factors may be altered in various disease states, example in case of the acute phase response, malignancy, as well as the autoimmune diseases. The 20% of the leg thrombi embolize with a higher incidence in above knee clot than below knee clots. Larger clots may lodge at the bifurcation of the main pulmonary arteries, causing hemodynamic compromise. Smaller clots will travel more distally, infarcting the lung, causing pleuritic pain. These are more commonly multiple and bilateral and are found most often in the lower lobes, where blood flow is the greatest. The thrombi can also develop in the right heart following myocardial infarction. The septic emboli also are found in the endocarditis in association with the intraventricular septal defects, AV shunts, or the central venous accesses. The Virchows triad describes the three broad categories of factors that are thought to contribute to the thrombosis. The clinical features of pulmonary embolism. The features could be circulatory collapse in a previously well patient. There can be hypotension with or without loss of consciousness in about 1% of the patient. Usually, it is due to the extensive pulmonary artery occlusion from a massive PE causing marked hypoxia and hypocapnia, and acute right heart failure with raised JVP and fainting on sitting up. Additional features include pulmonary infarction and hemoptysis in about 60% of the patients, isolated dyspnea in about 25% of the patients. Circulatory collapse can also be due to the poor reserve in about 10% of the patients, which may be due to small pulmonary embolism, often in an elderly patient with limited cardiorespiratory reserve. These patients can rapidly decompensate with even a relatively small pulmonary embolism. The clinical findings may be non-specific and reflect an underlying disease process rather than the PE itself. The DVT presents as an acute to subacute onset of pain, swelling, and redness of an extremity, usually a lower extremity. On physical examination, the patient may have fever. The extremities may also be found to be swollen, erythematous, tender, and warm. The Hoffman sign, that is the pain on dorsiflexion of the foot, may be present. Signs may be normal, or there may be tachycardia and tachypnea, which are a very common finding. Additional features include atrial fibrillation, reduced chest movement due to pain, pleural rub, classic loud P2 and splitting of the second heart sound with a gallop rhythm in case of the acute right heart strain. Hypoxia with hypocapnia due to hyperventilation and an increased alveolar arterial gradient may be there, but the partial pressure of oxygen may be normal in case of the young individuals, and signs of DVT are common in around 25% of the patients. If there is right heart failure, the features could include low cardiac output, raised JVP with reduced BP and perfusion pressure. If pulmonary embolism is suspected, the initial test that should be done is the arterial blood gas analysis and the D-dimer. The classic blood gas pattern associated with PE is decreased PaO2, decreased PaCO2, and an increased AA gradient. However, this pattern is seen in other conditions as well, such as the panic attacks and the infections. The hypoxemia may not be present in about 10 to 15% of the cases of PE. The CTPA is the gold standard investigation and is now recommended as the initial imaging technique in suspected non-massive PE. It has sensitivity of more than 95% and may enable an alternate diagnosis to be made if PE is excluded. It should be performed within 1 hour in suspected massive PE and within 24 hours of suspected non-massive PE. Lower molecular weight heparin is as effective as the standard unfractionated intravenous heparin and should be given to patients with intermediate or a high pretest clinical probability prior to the imaging. Unfractionated heparin should be considered in massive PE as the first dose bolus prior to the commencement of lower molecular weight heparin. Oral anticoagulation should only be commenced once the PE is proven. The target INR should be from 2 to 3. When it is achieved, heparin should be stopped. There is an emerging evidence to support the use of thrombolysis in certain subgroups of patients with pulmonary embolism. However, this is a controversial area and the risk-benefit analysis of the treatment must always be carefully considered. The other treatment options include embolectomy as well as the IVC filter placement. The indications for these should be carefully considered. Thank you. Please do like and subscribe my channel.